over to Dr. SK Mathur sir to introduce Dr. Rajasekhar Reddi sir to take the forum forward. I request all of you to please maintain decorum during the proceedings. It is a very, very important topic, and don't think that we don't get patients of autoimmune encephalitis. We do get patients of autoimmune encephalitis. We should be ready to diagnose them and treat them as early as possible so that the sequelae are that far less. Over to Dr. SK Mathur sir.
Good evening, friends. Thank you, Sushil, for a small introduction of whatever you said. It's more than what I deserve. Nonetheless, thank you so much. Today we have a very important topic, though not very common, but very challenging to manage. I would like to, none other than Dr. Rajasekhar Reddi who is going to enlighten on the subject, and it is going to be a very interesting talk and very, I would say, understanding and knowing about the autoimmune encephalopathy, which is not common. I'd like to share a small experience of mine with autoimmune encephalopathy. There's a family friend of mine, so I'll just share about this journey. Family friend of mine who was not well, I was called at about 12 a.m. in the morning by her daughter that she is not feeling well. And I went and saw her. She was at the hotel and she was not behaving well, incoherent, not being able to stand with herself, and not able to say feel normal and alive. So we suspect that she is not oriented to time place person. She is shaking her hand, not well. I suspect could be a CVA because she is no diabetic, hypothyroid, hypertensive, all comorbidity, an 80-year plus age. So I suspect it could be impending CVA. So I requested Dr. Rajasekhar to accept her and then we sent her to next Saket where she was hospitalized. Dr. Reddy evaluated her, investigated her, and diagnosed as autoimmune encephalopathy and treated very effectively. She was treated well and she was discharged from the hospital. What happened later I am not going to talk about, but that's the incident that she was treated so effectively by Dr. Rajasekhar and she was all right after the hospitalization. But I'd like to hand over further about that, and thank you so much.
Thank you. So, Mathur, thank you for that introduction. And it was a recent, case that we saw together. It was less than maybe about 3 months ago that this lady came to us. And like I said, sometimes over the years we've realized that everybody who comes with altered sensorium is not just low sodium or some kind of metabolic encephalopathy. There are certain underlying problems which we are beginning to recognize now in the last few years. So I'm going to talk about that condition, and if it's all right with everybody, I'll just start the talk so that we have a little more time to enjoy the dinner and everything else after. Is that okay, sir? Yeah. So, again, I want to thank all of you for being here today. So I'm going to talk about something. I'm not sure whether this topic has been covered in this forum before, but I want to bring it up here because, when I tell you the symptoms of this condition, all of you will see that these are things that many patients come to us with every day. And, I think about 10, 12, 15 years ago, when we didn't have this array of tests to do for these people, we diagnosed them with metabolic encephalopathy and all sorts of diagnoses were made. And I think that some of them, unfortunately, didn't do very well because of the absence of understanding of the disease. And I'm saying that this is going to evolve. In the next 10 years, we will have even more information about how to do tests, more understanding about the brain, more understanding about antibodies that affect the brain specifically. So basically, what is encephalitis? I want to tell everybody here when I say people when come to the emergency and I tell them she probably has encephalitis, they have never heard of it. Attendant. I tell them this is like appendicitis. You have a patient who has an inflammation of the brain, it is called encephalitis. And there are a multitude of reasons why this can happen. And infections, of course, we worry about most. But this is a little unusual condition, and it can be a very longish and little tedious topic for people who are not doing this every day. But I try to take you through the course and give you a kind of a bird's eye view of what we understand of autoimmune encephalitis today. And I want to tell you that the margins of psychiatry and neurology are being blurred by some of these diseases that we see these days. And like Dr. Mathur mentioned, this lady had come in and she was 80 plus, so there was this CVA head and urinary made 10 pus cells aa gaye, so that means it's a UTI. But there was something not quite right about her and the way she was behaving, and we did certain tests for her, found out that she had autoimmune encephalitis. We treated her for that, and she recovered very well, and she went home. And then subsequently, because of various complications due to secondary infections as a result of just her immunocompromised state, she eventually deteriorated. But I want to just tell you that, at that time when I was telling sir and we were talking, and sometimes it's like, when we're hearing such new things, all of us get a little shaken up, and the family was also quite shaken up. But I want at least all in the physician fraternity to have a good understanding of this condition. So, first of all, autoimmune we all are very familiar with. All of you are treating patients with autoimmune diseases. So broadly, when you have autoimmune encephalitis, these are immune disorders that primarily target CNS antigen. And then we have systemic autoimmune diseases, which all of you are familiar with, in which there are CNS manifestations. So you have your usual, your SLEs and your Sjogren's and your Wegener's granulomatosis, sarcoidosis. These are the percentages of patients who have neurological manifestations in this condition. Now, I'm just bringing it up here to tell you that autoimmune encephalitis is brain related. We are not talking about these conditions. So we are not talking about these rheumatological conditions in which the brain is involved. This is a separate entity. These have various pathologies and pathophysiologies through which the brain is affected. And these are a list of things that can cause seizures and strokes in these groups of patients in systemic autoimmune disease. I'm not talking about primary autoimmune encephalitis right now. So what do we do here? We treat the basic disease, we give immunotherapy and anti-epileptic drugs. But in autoimmune encephalitis, we have immune disorders that are primarily targeting CNS antigens. That's what we are talking about here today. And this is, like I said, it will appear like a rare group of conditions, but we see it more and more often every day. Every month, I would tell you that I would have about at least 7 to 10 patients now that I deal with who have this condition. So, we don't know the true incidence of this condition. We have no population-based studies, but hospital-based studies have revealed that 15% of patients without any genetic, structural, metabolic cause of altered sensorium or seizures have autoimmune encephalitis. And these epilepsies of unknown etiologies constitute about 1/3 of the epilepsies of unknown etiologies are as a result of this autoimmune encephalitis. Even if you look at adults who have come with epilepsy, it's been seen now that 5 to 7% can actually be because of autoimmune encephalitis. So, as far back as 2002, I think that was when Dr. Chauhan started the group, maybe 20 years ago, autoimmune epilepsy was first suggested as a terminology. And it took 15 years for the International League Against Epilepsy to actually include immune etiology among all the various etiologies they talked about in epileptic patients. And so I'm just talking about seizures in these group of patients here. Now, what is autoimmune CNS disease? Broadly, there are 3 groups of antigens that are targeted. One is what is called a neuronal surface antigen. Then there is the intracellular neuronal receptors and the glial cell receptors. And then there is a list of other things which can also happen, but I'm going to broadly talk to you about these important autoantibodies that we recognize now. So intracellular antigens, which are there in autoimmune encephalitis, are predominantly related to malignancies. And you have your anti-WHO, anti-CV, anti-amplifycin, anti-MA, anti-GAD antibodies. All of you have read about this from your, MD and MBBS days, but now we are doing these tests almost all the time. The newer surface antigens that we're talking about these days are these slightly unusual diseases that we're talking about nowadays, are BKGC complex related disease, which is LGI1, CASPA2, NMDAR, AMPA. And I'm going to just show these names to you because there's a lot of detail about this that I'll talk to you about later. But I'm telling you that nowadays what we do is we just have a panel of tests. The moment we suspect that this patient has a problem, we send one blood test. It covers a host of these antibodies, like there are 10 of them or 15 of them there, and we know that, okay, this particular antibody is there in a particular patient, and we know what to do about that. So, if you look at the time frame of detection over the years, as you can see, right from the beginning, where you start off with ANA 1, subsequently till the last, which is a GFAP related disease, we have tests which are detecting all these right now. So, this is the bunch of neuronal antibodies. And I'm telling you that these are now standard tests in hospitals. It has become such a problem now that people are, to my mind, overdoing it a little. Any person who has altered consciousness, any person who has psychiatric abnormalities, any person who has any kind of dementia which is not completely explained, now these tests are happening. But I think it is important to try and do as many tests as possible in these groups of patients if you're not very clear about what the diagnosis is. So, I'm not going to talk to you too much about this, but basically seizures in this group of patients can happen because of two reasons. One, as a presentation. When they have a problem, they come in. And in some people, as a result of autoimmune encephalitis, there can be an enduring predisposition for seizures. In both cases, they're quite difficult to control with anticonvulsant drugs, and it sometimes takes a multitude of drugs to control seizures. So if you have a patient who is coming to the hospital requiring 3 drugs, 4 drugs, and this is like a, let's say, a 60-year-old man who suddenly comes with seizure, and now is not controlled with 1 drug, 2 drugs, you must start thinking that this is not straightforward epilepsy of adult, what we call late onset or late adult onset epilepsy. There is something underlying, and we must start looking at these tests for this. So, again, because these terminologies are going to be new to you, I don't want to sort of dwell too much about this, but I'm just going to talk about a few things here, because now we know a little bit more about these antibodies. We've followed up series of patients with these antibodies which are positive. We have a little bit of idea about each antibody, what it does. So I'm going to answer 2 questions here. What are autoimmune encephalitis that present with seizures, and what seizure patients are likely to have autoimmune etiology? So these are the antibodies that we test for, and again I'm trying to say that it will look unfamiliar to you, but over a period of time you will see that these are common names, and I'm saying 5 years from today, all of you will be writing autoimmune encephalitis panel in your OPDs. This will what will happen. It will come psychiatric illnesses, altered consciousness, cognitive impairments, all come under this spectrum, under this rubric of autoimmune encephalitis. So there are certain surface antigens which commonly cause seizures and certain which are rare. So this is the list, and in this is a list where these do not present only with seizures. There's more than seizures that happen to this patient. So at the end of the day, when you talk about these patients, it's not only seizures, but apart from focal seizures and seizure clusters, status epilepticus, and refractory seizures, sometimes we will find that these patients also come with cognitive impairments. And if a patient has come with a dementing illness which is rapidly progressive, today autoimmune encephalitis is the first thing we must do. I have a patient I saw in the OPD today, and this is the 4th patient in this family who has got Creutzfeldt-Jakob disease. And the first time they came back to me saying that their chacha had been diagnosed by me in 2004. And I'll tell you that when that person came, I'm just giving you a little bit of a history about this gentleman. He is flying back from Dhaka to Delhi. I remember this person because he walked into my room, and I told him that history, and he couldn't believe that I remembered what happened 20 years ago. While he was filling out the immigration form in the Dhaka airport, he could not fill the immigration form properly. And then they noticed that he was disoriented, confused. He got into the flight. He came in. He flew to Delhi. Within 1 day, he rapidly deuterated. He started having jerks. And he was brought to my OPD. The moment he walked into my room, my first thought was this person has potentially CJD. And then they saw me, and I said that he has CJD. We did an MRI, proved that he has CJD, and he went up to GB Pump, because the family tell me now that they thought I was too young at that time, which I don't blame them for. So,
repeat it, sir. Repeat it. When was this?
This was in 2004.
You're still young. I'm back, sir.
20 years.
You're still young.
Thank you. So now the family has come with a person in 2015 who has again been diagnosed with CJD. At that point of time, that patient was taken to Singapore. They did a CSF 1433, proved that the patient has CJD. A third person gets it in 2019, and a fourth 49-year-old lady has got it now. And now they have come to me saying, can it not be autoimmune encephalitis? And I have to talk to them about the fact that it's very unlikely that autoimmune encephalitis can happen to 4 people in the family. Even CJD to happen to 4 people, Creutzfeldt-Jakob disease, to happen to 4 people in the family, clustering is well known, but it's not very common. So this person now has gone and got out articles where they say that mimicking autoimmune encephalitis, mimicking CJD, so we want you to treat her. So now I've got her into the hospital, she's going to get admitted tomorrow, and then we'll start her Moderator, because they said, anyway we're going to let her die if she has CJD, so I want to treat her for autoimmune encephalitis. I'm just trying to say that 20 years ago, this word was not there. We didn't have antibody testing, we didn't have anything. Over the years, it has started mimicking every possible condition that we can think of. So we are getting this more and more often, and I'm just giving an example. As recently Dr. Mathur's family, a very close family friend had come to me with the same condition, and this person I'm telling you about now. So these are various conditions or various clues that one must think of. If there is a multifocal bizarre presentation, if somebody comes with a weird psychiatric presentation, and in a person who's completely normal otherwise, let's say somebody's lived a perfectly normal life till 40 years of age, and suddenly starts having weird presentation. Like, there's some behavioral change in the family, or some sort of newer psychiatric thing. You need to start thinking now. If there is a stuttering subacute cause, if there are certain cancer risk factors, if there is a family history of systemic autoimmunity, there is a family history of malignancy, of course MRI and everything else is also important. Now what is NORS? NORS is a terminology we use for new onset refractory status epilepticus. A patient comes to the hospital, never had a seizure in their life, and suddenly will have seizures which are so difficult to control. And within 24-48 hours, we are giving them 4 or 5 anti-epileptics. The terminology that we use for this is NORS, new onset refractory. So 15 years ago also we had it. But after following up these patients, now we are seeing a large group of these patients turn out to be autoimmune. So we are very aggressive about starting steroids, about doing plasma exchange, giving IVIG very early into the course of illness. I had a patient who presented me recently. She is the owner of a parlor in Saki, and within 1 or 2 days, she rapidly declined and she got florid status epilepticus. And she continued to have eyelid myoclonus and forehead myoclonus for almost a period of like 72 hours. And I had 5 drugs ongoing. Her children were in the US, they came back, and they couldn't understand what was happening. And she had been referred to me by a cardiologist, Dr. Samanjoy Mukherjee. So, I kept telling them that this is probably some sort of autoimmune encephalitis. We're doing tests for that. And finally, we had to give her rituximab after doing IVIG and plasma exchange. And she recovered completely. She's back to normal. She's absolutely normal. Only fight with me that now that is the argument that I have with her every month. And I'm thinking like, she had so many seizures, I put her on so many drugs. Sometimes when you give a lot of drugs, it's like making a very tasty chutney. You've controlled everything. If one ingredient comes out, the chutney goes for a toss. So sometimes anti-epileptic drugs are like that, and it is sort of very difficult at that point of time to really be able to decide what to take off and which one you should take off, and so it's sometimes it's like that. So anyway, so I'm going to not these are some of the classic presentations of these conditions. In LG1, and I will show you a video of a woman who had that, and I will give you the history. There's something called a facial-brachial dystonic seizure. So they'll go with one hand and their face like that. They will go like that. And so a year and a half, 2 years ago, 80-year-old retired doctor couple from the UK. Very well heeled, multiple properties in the UK, have come to India for a holiday, have been seen in the UK. She's been told she has cognitive decline, probably Alzheimer's early onset. She comes here, she has a small bleed in her brain, admitted under neurosurgery, and suddenly starts having seizures with jerks like that. And the neurosurgeons are not, she's got a small bleed, and they're not figuring out, they give her 2 antibiotics, suddenly they call us. So I see her, I talk to the family, and she's had this 6-8 months of history where she's stuttering, and because she was 80, everybody said that, you know, she has cognitive impairment as a result of age. We quickly chased her down, did everything. This was about 2.5, 3 years ago, before the COVID actually. And found out she had autoimmune, treated her, she recovered completely, splendid, back to normal. And then there is immune suppressive medications that need to go on, unfortunately, in some of these people. And then during COVID, she got COVID twice, and the third time we couldn't put her out. But I'm just saying that, you know, because she had an intraventricular tiny bleed, and she was having a refractory status epilepticus in the neurosurgical ICU, which the neurosurgeons could not make head or tail of. And then when he came back with the history, luckily with a doctor, so he was able to give a very good history about her. So I'm just saying, we keep seeing these cases again and again. And you have, now I told you that certain antibodies have specific kinds of presentations. And when you start reading more and more about this, you will see that there are, I'm just mentioning one of them to you. So all these are the different things that we are talking about. And again, I was telling you about new onset refractory status epilepticus. This is a multi-centric study of 130 patients. 47% had etiology, and you could see here that a lot of these turned out to be anti-GAD and anti-NMDA positive, and they were treated and they got better. So our overall approach to these patients is, first of all, do your standard workup, do all the metabolic workup, do a CSF, MRI, EEG, all that stuff will happen. But please do the paraneoplastic antibody panel, both in the CSF and the blood, and a lot of them, we need to do a PET CT whole body also, because some of these are going to be associated with malignancies, especially the intracellular antigens. You know, the ones I told you about, anti-WHO, anti-amphiphysin, etc. There are different ways to do this. The microbiologists will tell you that there are many ways, but the best is the cell-based assay. Everything else, immunoprecipitation, immunohistochemistry, is not so sensitive or specific. And both CSF and serum both need to be tested. This is the cost of the Autoimmune Encephalitis panel. This is a little more expensive than now. It's about 28,000 rupees. But these are the complete panel. And when we have a suspicion, we don't usually wait to do one at a time. So if I think clinically that this is LG1 related or this is a Casper2, I will not only do for that. We do the entire antibody panel because we can't waste time. You cannot, and many of these have very similar phenotypes. So you can't discern often. So the idea is do the entire panel. This is another lady we had recently. This is a report from Max where you see a GABA B receptor. It was a weak positive. We treated it, got much better. So EEG, etc. And these are the MRI findings. And you can see 3 conditions. If you saw this MRI as a radiologist, the first thing you would say is herpes encephalitis. This is typical of herpes, medial temporal lobe involvement, hyperintensity. You can see those little white things in the medial temporal lobes. And these are the different antibodies which have caused exactly a similar picture. So, and again, these are again more examples of that. So I'm not going to go into too much of details, but this is an anti-NMDA receptor antibody. Here at baseline, there's a viral prodrome. After that, a lot of psychiatric manifestations. Then there is a stage where patients get worse. They are catatonic, they have dyskinesias, they have autonomic features. And after that, they have a prolonged recovery. And here, as all of you would know, there will be many patients that you are familiar with who may have got a viral infection, a viral encephalitis, had this exact course without ever being considered that they had autoimmune encephalitis. So this is the EEG findings, and again, I'm just showing you some MRI findings. This is what is called a NEOS score. We look at 5 things. We look at the ICU admission, if the patient has ICU admission. You look at the treatment delay. You look at lack of clinical improvement within 4 weeks of normal MRI, the CSF showing more than 20 cells. If your score is high, the higher the score, each point is 1. The higher the score, the less likelihood of recovery. And what's important here is, you see the second point, treatment delay. If there is treatment delay or a lack of clinical improvement within 4 weeks, which emphasizes the fact that you need to treat fast, you need to identify fast, you need to treat early. these are autoimmune encephalitis triggered by herpes simplex virus. Some patients with HSV encephalitis, if you follow them up, you find out they actually turn out to be NMDA receptor encephalitis. This is LG1. Again, you will see that hyponatremia is a very, very common. This is the faciobrachial dystonic seizure that I was talking about. And behavioral changes, insomnia, tonic-clonic seizures, and you can see how immune therapy changes the course. So, again, anti-epileptics in this group of patients have to be chosen carefully. This patient can have rash. So some of the drugs that cause rash, such as carbamazepine, etc., you should be careful about. GABA B receptor encephalitis. And what is the treatment approach? We use something called a antibody prevalence in epilepsy and encephalopathy score. We have 7 points in the score. If you have a score of an APE2, which is APE antibody prevalence, epilepsy and encephalopathy is E2. If it is more than 4 out of these points, you can see new onset, rapidly progressive mental status changes, new onset autonomic dysfunction, neuropsychiatric symptom, history of underlying malignancy within 5 years of having a neurological diagnosis, faciobrachial dystonic seizures, facial dyskinesia, seizures refractory to more drugs, CSF protein more than 50 or WBs more than 5, MRI findings which are more. If you have a score of 7 or more, 100% specificity and sensitivity for diagnosing autoimmune encephalitis. 100%. So if you have this score and you start ticking these boxes, and you see that, and if it's a score of 4 or more, 98% sensitivity, 85% specificity for having some sort of autoimmune encephalitis. And I can add to that score by, this is called a response to immunotherapy score, we won't go into the details of that. So the idea here is, if you have a suspicious immune etiology, autoimmune epilepsy, you do a good history, look at all the differentials, look at metabolic, neoplastic, degenerative, all these things. You look at the bloods, usual bloods, you look for evaluation. If the antibody evaluation is not available and the APE score is high, you still give an immunotherapy trial, and if there's a favorable outcome, it is likely to be autoimmune encephalitis. If there is a lack of favorable outcome, you look at the APE score and see if the score is high, then it is likely to be autoimmune. If it is not, then it's probable. If it is negative, then again you go through this whole chart, looking at the APE scores, and if it's positive, obviously there is a definite autoimmune encephalitis. The treatment is to give IV methylprednisolone as #1 choice. #2 is IVIG, and the third is plasma exchange. I prefer plasma exchange. It is the most efficient form. IVIG, the different. So for all immune-mediated conditions, whether it's a myasthenic crisis, whether it is, let's say, GBS, you have these options, right? My logic here is that if you give IVIG first, and you give plasma, and the patient will improve, and you give plasma exchange after that, you wash out the IVIG. So if you go the other direction, you give plasma exchange first, and then in case the person doesn't respond, you can still top it up with IVIG. The downside of this is IVIG is safer. Plasma exchange is probably got a little more in terms of issues related to, let's say, some hemodynamic instability, some coagulopathy, etc., which can happen during that time. So you have to be a little careful about that. So the treatment workflow is, do these treatments. If things don't work out, sometimes we give rituximab or cyclophosphamide immediately. And of course, if you find a tumor, treat that immediately. So these are various other drugs which are, rituximab, they're not very many. And some of you will be familiar with tocilizumab, which was used a lot in COVID, and the bortezomib is also used here. So the seizures, we use the standard drugs, but you need to understand that I don't want to go into the details of this. I don't think it's important for all of you to know. So important thing to understand here is that this is a autoimmune neurological disorder, very complex. Diagnosis is based on comprehensive clinical picture. Each antibody has a unique clinical finding, cancer association, and response therapies. Many autoimmune epilepsies have a high rate of seizure remission and after proper immunotherapy. Early diagnosis and treatment drastically alters the course of disease. So what are the features that make me suspicious? I told you again, short history, neuropsychiatric abnormalities, memory disturbances, cognitive impairment, seizures, tremors, faciobrachial dystonic movements, sleep disturbances, fluctuations. Also, typically imaging findings. These are the various, cancers associated with different antibodies. So takeaway are that seizures are a frequent manifestation of autoimmune encephalitis. Sometimes we do prolonged monitoring. If there is a refractory seizure, then you have to be more suspicious. Early immunotherapy. And most of these cases are such that they respond. So I'm going to quickly, my last few slides is to show you this case. This is a 32-year-old female teacher. She was evaluating well till 10th of July with increasing changes in behavior. Family related it to anxiety due to a death of a neighbor. But she continued to have these behavioral changes. She is 32. She was shown to a psychiatrist. No change in her behavior with medication. Admitted in an academic hospital outside of Delhi. Clinical condition remained same. She suddenly developed incontinence to experience. Now this is a very important thing. Unless you have depressive stupor, please understand that psychiatric patients, however bad they are not likely to be incontinent to urine. That's not normal for psychiatric patients. She remained a little hyperactive, had reduced sleep also. Then she started having seizures. 31st August, shifted to Delhi, admitted an enteric encephalopathy. There was some improvement in her aggression, discharge of her medication. She would resist medication, she was apprehensive, scared, had memory changes. Came and got admitted. She was conscious, occasionally would recognize her pain, irritable, extremely fearful, but some would be able to still walk without support. So we did the usual thing, and then we found out the MRI showed limbic hyperintensity. The earlier MRIs had not been good enough to pick that up, and eventually a serum NMDA receptor antibody was positive. A PET was normal, EEG was normal, everything else was normal. And this is what the MRI looked like. And this is a follow-up MRI when we did the follow-up. And this is what she looks like, and I want to show you this. You'll never forget this. This is the facial-brachial dystonic seizure. And this is classic. So this lady had this, and eventually, I'll show you that again, so you see that? And we gave her IV with albuterol, later IV pulse, dramatic improvement, and steroid taper for 4 months, doing well. CT scans have been done and follow-up also, which are completely alright. So I want to show you a case who was initially treated as a psychiatric problem, and there were clues in that history that didn't add up. Absolutely okay before 32 years of age. And and then this urinary incontinence, stool incontinence, all these strange things that were happening. So, and then finally, she's completely back to normal. So thank you everyone. I just want to do a very bird's eye view, and I want to thank everybody else.
Please come.
Thank you.
Short and graceful.
Friends, we had a wonderful session, and I'm sure you're going to observe the decorum which you maintained during the talk. We will have a question-answer session for half an hour, which we are supposed and obliged to wind up at 10:15. Please be specific to the questions, ask questions which are relevant to the talk and relevant to everybody in general. So wonderful talk, Dr. Reddy sir. Can I just ask a very simple question, sir? It says autoimmune encephalitis, but it can also be autoimmune encephalomyelitis. Am I right, sir?
Right, so absolutely. So when you use the term myelitis, we're talking about the spinal cord. Right? So if you look at the various antibodies that are there, most of these antibodies that we're talking about for this condition will specifically affect the brain. It is white matter diseases in which the spinal cord gets affected. So this would include diseases like neuromyelitis optica spectrum disorders, in which we now include anti-NMO antibody and anti-MOG antibody, as well as in conditions such as multiple sclerosis. In certain patients, you have what is called an ADEM, an acute disseminated encephalomyelitis. So in the past also, children with this condition will come, and routinely they will be treated as a viral trigger which is caused an ADEM. And this ADEM is usually a monophasic illness. So they're given pulse with albuterol, IV, IG, whatever, and many of them recover very well. But now we know that the trigger could be some of these autoimmune encephalitis panel thing. So many of these will present with that, and we now routinely check all our children. Even children who are 5, 6, 8 years old who come to viral infection ADM, we check for these auto antibody panel.
Thank you, sir. Sir, it's very, very nice to hear this term autoimmune encephalitis. But CNS involvement with autoimmune conditions, we are not stranger to those. And even transverse myelitis, many times, is supposed to be having an autoimmune basis. Your comment?
So, see, basically, even any immune-mediated disease which affects the spinal cord of the brain is, correctly like you said, is an autoimmune condition. See, the transverse myelitis of the past that we talked about were either part of multiple sclerosis or, like I said, isolated transverse myelitis. Isolated transverse. Those could be even part of some systemic autoimmune disorders such as SLE, such as other rheumatological conditions in which there were myelitis. These conditions are slightly different from that. So transverse myelitis, we would look at another different set of things. Like for example, if a person comes with a long segment, so I broadly classify myelitis or myelopathy into two types: compressive, non-compressive. Compressive में क्या होता है कि there is a metastasis or there is a collapse of a vertebra or there is a trauma which is pressing the spinal cord. Non-compressive myelopathies are in which there is cord involvement in the absence of any compression. Subacute spinal degeneration of the cord, like B12 deficiency, SACD. HIV-associated myelopathy. HTLV, which is again a viral, which is tropical spastic paraparesis, it causes. Then, I told you already, NMO spectrum disorders. So there's a differential angle. We look at sarcoidosis, which affects the spinal cord. We look at Lyme disease. So all these conditions are what we call myelitis per se. This is, like I said, in this condition, myelopathy is not that common. I wouldn't worry about the myelopathy. Don't worry about the spinal cord for these autoimmune conditions.
Sir, it is also true that some of these conditions, autoimmune encephalitis, they are related to particular tumors. Suppose there is a teratoma in the ovary. And at times it helps to remove the teratoma to help cure or remedy the patient. Your comment?
Absolutely. So first treatment would be also, we are now realizing that certain antibodies are associated with certain specific diseases. So suppose you have a particular type of antibody that is more likely to be associated with thymoma, we will look at that part. Or we know that this anti-Hu, for instance, is associated with lung cancer. So we will look at the lung more carefully. So those are the kind of things, and you're completely right. If you treat the basic disease, then often the neurological manifestations may remit by themselves.
So you mentioned some cases and you showed some wonderful cases. Once you treat them with IV methylprednisolone or IVIG or with other modalities, do they recur?
So there is a risk of relapse, and that's why most of these patients are given a prolonged course of steroids, unlike the steroids that we normally give in patients who have, let's say, any other, we take it off steroid in 15 days, 20 days, with the usual things that we treat people in the outpatient. Now this condition, you have to give prolonged, and sometimes you have to give steroid-sparing agents such as azathioprine and mycophenolate. Now, I understand that when you give long-term steroids, there's going to be a risk in that. I've had 2 patients in my life who have had infection-related complications. One was a patient who I gave long-term steroids for temporal arthritis, and he recovered completely, and I had to do a very slow taper. He developed a norcardiosis, which was a tuberculosis I'm not even going to talk about because that's not such a concern for us. And the other patient very recently got a PCP pneumonia. But the recommendation is to gradually taper, because if you taper too fast and they relapse, then you're dealing with that. So you have to taper it over months, usually about 2 to 3 months at a minimum.
So once you diagnose autoimmune encephalitis, And as I understood from the talk, sir, the first line of treatment is IV methylprednisolone, usually. How do you decide this patient qualifies for IVIG, which is usually a very costly treatment in itself?
So, see, ideally all patients should be given IV methylprednisolone. It is the most rapid acting drug, it is the cheapest and the most effective. So IVIG is never sort of given in lieu of IV methylprednisolone. So we would sometimes think that, okay, this patient is very sick. For example, if I have a patient with a necrotizing myelitis, and I think that, don't wait. Give the IVIG immediately with this methylprednisolone. I would sometimes do that because if I think that this is too bad for it to recover only with IV, I don't want to wait. I don't want to give more time. The criticism of this has been that if you do 3 therapies at the same time, you're in no way to, if the patient becomes better, you really can't judge which really worked. So there is that criticism, but in certain conditions we don't wait, we end up giving both together.
Sir, in what percentage of your cases of autoimmune encephalitis you take resort to IVIG?
I think that usually it would be in around about 50 to 60%.
So it's every second patient you take recourse to that?
Yes.
Right. Sir, what does the course, the
I
entire
do
course?
plasma exchange, I prefer plasma exchange, I do that.
You said that, sir. You said that.
IVIG is my third choice.
Which is cheaper, sir? Plasma exchange or IVIG?
Plasma exchange is cheaper, but results in longer hospitalization.
Sir, I'm sure for this enlightened gathering, I would recount one of my own patients, my Mosi ji, Mrs. Usha Chauhan, who was admitted under you with severe myelitis. And you said that she had necrotizing myelitis. She didn't respond to IVIG. Neither did she respond to IV methylprednisolone. I think you had considered plasma exchange. I don't remember exactly whether she got plasma exchange or not.
This was actually, if I remember, Rajan, maybe about 15 years ago.
Yes, sir.
But maybe
10 years.
10, 12 years.
10 years.
Again, that long back, at that time, again, our knowledge of these conditions was limited. We didn't even have a lot of the antibody testing that we do today. And see, the thing about neurology is that if you lost tissue, the chances of recovery is very little. So we have to try and save neurological tissue before you lose it. So unlike the heart, the brain or the spinal cord is not forgiving. एक बार खराब हो गया तो फिर उसके बाद ठीक करना बड़ा मुश्किल है. So paradoxically, I have to tell patients who are well that if you don't get treated, if I lose this function, you will not get it back.
Sir, my last question. You mentioned, 1 minute, Neeraj, please. We are in for discussion. Don't talk. Sir, you said the antibody panel now costs about 29,000 rupees.
25.
If we do the entire antibody panel, sir, does it guide us as to the therapeutics of autoimmune encephalitis?
So see, once you've proven that you've found a specific antibody which is positive, or let's say you do a paraneoplastic antibody panel positive, you're guided into looking at a specific thing, and then you have more reason and more justification to give therapies which are quite strong. They have their own side effects. So I've had a patient with very severe vertigo. She would keep lying down on the bed and she would not even open her eyes. And she had been treated as vestibular neuromyelitis by everybody, but for the 4 days she was in the ICU, and when we examined her, she would not even allow us to send her up. But there was, to my mind, a cerebellar syndrome more than this. We did a paraneoplastic antibody panel, and she turned into anti-U positive. Then we did PET CT, and she turned into a CA breast. We treated a CA breast. She had just come with vertigo. She had come from Panipat. And 4 doctors had seen her. And I'm not blaming them because at the end of the day, chakkar aa rahe hain. Our first thing is to give birth. But at the end of the day, if there is something peculiar about that patient, then we need to make sure that if you get uneasy about seeing somebody, my thing is that you'll just be a little cautious about labeling them. Because once that label happens, then they carry on with that label forever. So it happens that we have to be a little cautious in this group of patients.
Dr. Reddy, you gave a very strong statement that most of you will write this panel maybe in few years' time. So this is long panel, very costly also. So by that time, can we come down to fewer tests because so that every physician in suspected cases can go?
So the thing is, there are two aspects about marketing. See, first of all, I want to tell you that many conditions will look similar. Okay, so the phenotype of these many conditions can look like one. So if you do only one antibody and it comes back negative, then you think it's nahi hai. So second is that you save time. So I'm saying that as we use this more and more, you will get to much. See, I told you. So
ये बंद कर दो, ये वाला बंद कर दो.
Sorry. It is blurring the margins between psychiatry, neurology, as we go. Now, let's say somebody is 80 years old, comes with some forgetfulness. We don't want to just say, acha, if the person very specifically has a very typical history of Alzheimer's, MRI, everything suggests about this thing, that's fine. But if there is something strange about their history, then these days we are very, very cautious. We don't want to label everybody. And this can turn the other way also. कि सबके लिए टेस्ट कराना शुरू कर दिया कि किसी को भी psychiatric manifestation हुए तो सबको आपने टेस्ट कराना शुरू कर दिया. So we have to guard against that, and we need to be cautious and we need to understand if there is some peculiarity, if there is something very abrupt onset, if there is something not quite right, then you need to change.
With time we will go wider also. So second question and last question, you mentioned malignancy 2-3 places. So what is the connection between malignancy and this?
I was telling you about the autoimmune encephalitis panel. There are two types. One is surface and there are intracellular and there are synaptic. The intracellular antigens are associated strongly with malignancy, some of these. So apart from the autoimmune encephalitis, we do a paraneoplastic antibody panel. These autoantibodies are also directed against CNS antigen. For example, paraneoplastic cerebral degeneration, limbic encephalitis, is occurring in CA lung. I met patients of CA lung who have come only with unsteadiness. We have done that and we have found that they have CA lung. Paraneoplastic cerebral degeneration can precede the diagnosis of a malignancy by 2 years. Okay. I've had a very famous and a television anchor's father come to me with ataxia for 2.5 years, and I kept doing tests to try and find out what nothing turned out. It turned out to be a BCD. He came with peritoneal carcinomatosis 2.5 years later. And so even at that time I had this inkling that he's going to turn out to be. But there was nothing to do, I couldn't find anything.
No, but in those cases, can you do that suspected malignancy panel also?
So we did all that. But the point is, at the end of the day, even without that, 50% of PCD are non-neoplastic. 50% are neoplastic. Okay? So if nothing is coming out, you can't treat. So we treated with steroid, we did all that thing. Symptoms will improve, but I was worried that something would turn out. And subsequently, it turned out, and his whole family thought he had psychiatric problem. And she is a very famous, news reader, and so I'm just saying that, and she's very understanding. She knew everything, so she was well there. Never had a problem, but it's still sometimes a difficult thing.
Thank you.
Friends, I think if anyone is entitled to ask a question from this learned gathering, it is one gentleman who is a DM Neuro, and I'm sure he should be asking the question before anybody else, or his opinion or his comments.
I think we should ask him questions.
Thank you, sir. Sir, it was a wonderful, always a pleasure to listen to you, sir. I always hear every word you say. Always a pleasure, sir. Sir, I have a few comments actually. Sir, I've also seen a quite few autoimmune encephalitis patients. Sometimes what happens that we have a typical clinical spectrum, the subacute onset of cognitive decline, unexplained seizures, neuropsychiatric manifestations, etc. We do all the workup, including MRI, EEG, CSF and serum. Everything turns out to be negative. And in some of these cases, PET CT of the brain helps actually. And the take home is that we should, if we have a strong clinical suspicion, we should not wait for the antibodies report, and we should start the immunotherapy promptly. because the promptness with which the treatment is given decides the outcome. And another thing, sir, as sir told that there are two types of cell surface and synaptic antigens and intraneuronal antibodies. The response to immunotherapy is better in the the cell surface associated antigens. So it is, and another thing is that PET-CT, of course, PET-CT is helpful sometimes because a certain pattern of cortical hypermetabolism is highly suggestive of autoimmune etiology.
Completely agree with you. Absolutely.
Yes, sir.
Wonderful comments, Dr. Bhaskar, and very, very valid points. I'm sure. One more thing Dr. Bhaskar Shukla has to say.
So sometimes what happens is we give IVIG or without prednisolone, the patient does not get that well. So it is also important that we start the second line immunotherapy also very promptly. So I remember one of my cases during my DM. So he was a 10-year-old boy. So again he had some violent behavior, abusive, talking gibberish and all. He was shown to many psychiatrists. They gave him some medications, but of no use. He landed in our institute. We did the CSF and all, and we are completely positive. We treated him with IVIG because we could get that drug free of cost in our hospital. We did not show response. We gave him rituximab, and there was a dramatic response. And after that, all the cognitive decline and all everything turned out to be normal. And
Absolutely. I completely agree with Dr. Bhaskar. I think, like he said, early suspicion, early treatment, both are very, very important in this condition.
Dr. Rana has a question.
Sir, is there any panel for neurotrophic viruses also?
So we have a meningoencephalitis panel. It's called, we have that has a host of antigens of bacterial and viral. Not all, but it has several.
Dr. Reddi, thanks. Such a nice conversation. Bada acha laga, sir. My question is, sir, you said about HIV and you told about herpes also. My question is that there are patients who come to us with herpes zoster positive. Whenever we do the test, the herpes zoster IgM is negative and IgG is positive. And the IgG is very highly positive. And sometimes later, when they turn to be HIV positive.
You are talking about herpes simplex virus?
No, sir, zoster. Yes. Zoster. Sir, whenever they turn to be HIV positive, later on they are having severe problems with the neurological disorders. My question is, sir, is it relevant that if we find a patient who comes to us as a physician to our clinic and we find that IgG is positive and it's more than 30, 35, 40, sometimes it is 50. So what should be the role of a physician? Should we treat the IgG?
Typically what we do is we do these antibody testing for people who we are giving some immunosuppressive therapy. For example, if I have to give rituximab, part of the testing includes theoretically doing a quantiferon TB gold, which is not a good test, it's a useless test, but we just do it. And then we do hepatitis B, hepatitis C, etc. And in that we also do herpes zoster virus. Now, in that, the IgG, like you said, if it's positive, just tells us that there's been a past infection. And if there's a recent infection, you would have an IgM, which is positive. Now, the IgG having a hydrogen, you have to be cautious that in case they get immunosuppressed, there's a risk of reactivation of the cell. That's all. But it is not, it's not against giving the drug.
So my question is, what is the role of the titer? For example, a patient comes to you with an IgG of 5 or 6 or 10. But if a patient comes to you with a titer of 30, 40.
See, it's a remote infection. No, it still wouldn't qualify for you. So you, just like you mentioned, I gave my patient, I had this positive, I gave her rituximab for autoimmune encephalitis, and next, after 3 days, she developed this hospital. And in this patient, then because CD20 counts are depleted for 6 months, I gave an antiviral for 3 months.
So I gave
But there are patients with HIV, sir, may I say?
Yeah.
So there are patients who come to us with HIV positive and whose CD4 is less than 50, 40, 30. They're having severe problems with their body.
Once you're in that spectrum of patients, if you want to empirically give, especially if you're thinking that if you're giving any other therapy that will further impair their immunity, in that lot I would consider it. I don't think I remember any guidelines based on titers that suggest that we need to treat. It's remote infection, that's all.
Dr. Tulsi sir, sir, we have exactly 8 minutes left. 6 minutes for you and 2 minutes for Dr. M.L. Kala sir. Now you decide between you.
I'll take all 8 minutes. Let me start. Dr. Rajasekhar Reddi. That was really a fascinating talk as usual. So, JAMA Neurology this year, just few months back, talked about the misdiagnosis in autoimmune encephalitis. And what did they say? They said 50% of the patients are misdiagnosed. This is not in Apollo, Max or Fortis. This is at Mayo, Oxford, Washington, Texas, other prestigious universities. Yeah. So did you say 50% of the people are misdiagnosed in prestigious institutes? So tell us a little about the, how do you correct this? Is it, would you rely more on EEG? Would you rely more on, as Dr. Shukla said, the PET FTG, MRI, or the serum, biomarkers, say positivity or negativity? Or the clinical features which are very varied, in autoimmune encephalitis. Tell us a little about all this.
See, like I said, the first thing is that, whenever a person comes with a particular problem, if they don't have a very typical presentation, you should be very careful. So there's some atypicality. Like this lady with a psychiatric problem, she was incontinent to urine and stool. And sometimes when we hear that, we think that maybe it is because she has been given some medication. Was she given some benzodiazepine or antipsychotic in such a dose that caused the problem and she became incontinent? We are not even sure about that. But there were some, things to it. Second, I told you that it's a combination of clinical diagnosis, clinical acumen, along with very high suspicion. And like Dr. Bhaskar said, a PET CT of the whole body, these panels, an MRI brain, an EEG, a CSF examination, including paired CSF, both for CSF autoimmune encephalitis as well as the serum, should be sent at the earliest for these patients. Now, I understand that there is a cost, but if we are trying to deal with it, so I had a patient, I will talk to you about, a lady who was admitted under the pulmonologist. She came with aspiration pneumonia. Her sodium was 121. She had a seizure. So she recovered completely. She's completely normal after that. And had no complaints. She's a very pleasant lady. She wouldn't complain about anything. So we went and we saw her and we said, look, there's a... And then when we talked to the family, they said, look, for the last 3 weeks, she was not... So we thought, okay, maybe it was just hyponatremia, slowly developing, and she was actually getting... She was very old. She was about 62, 63. So as is our habit, we wrote an MRI. And we found that she had medial temporal lobe hypertension. And she was there. But I said, look, I'm first going to treat for why. I sent all the panels and I said, so it took 5 days for our panel turnaround to come. So by that time it came back, she had already finished 5 days and she had no symptoms. I continued that, but I gave her IV methylprednisolone and continued her on oral, and after finishing the vitamin, she perfectly, she's back home. Now, during this time, she had a seizure, she had a collapse of her vertebra. She required a kyphoplasty. So she was getting treated for hyponatremia. She was getting treated for the pulmonologist for this. I'm giving her antiviral. Now suddenly I'm saying that family thought that we've lost it. But luckily for us, some of these reports are there, so we give these reports to those people and they were quite. So sometimes I keep telling people that if you're driving a car fast and if you had alcohol and if you haven't slept very well, and you're talking on the phone, and if you have an accident, and you ask me why you had the accident, I can't tell you why you had it. I can only tell you that, look, you don't need all of those conditions.
Especially if you are driving a BMW, as Dr. Reddy has. Anyway, sir, let's proceed further and talk what, well on what Dr. Shukla said regarding FDG PET versus the MRI. See, in acute settings, probably the FDG would be more accurate as compared to the MRI. What do you say, sir?
The thing about functional imaging of any is it's a little more prone to interpreter observation. So you know, you have to understand that structural imaging has a little more standardization as compared to functional imaging. And when you do that, it's like it may look a little abnormal to certain people as compared to other people might not think it that way. So it's a little bit of that you need to be cautious about. In good hands, it is better. And I cannot tell you how lucky we get sometimes. I have had a patient who I saw in the OPD. Sometimes I think medicine is more luck than anything. But anyway, so I had this patient I saw on Monday in the afternoon. I see him in the OPD. His hemoglobin is 7.3. They won't follow up on that. I've seen him for the last 10, 12 years. They're from Jammu. They come and see me and go back. So I said, आपका hemoglobin कम है, suddenly कम क्यों हो गया? So डॉक्टर पता नहीं, हमारी कल flight है. So I said, look, I'm not comfortable. So she said, we'll cancel the flight, don't worry, we'll get admitted. So I admitted for an endoscopy and a colonoscopy, just to look for a GIP. He had no other things. And he was an old CVA patient with a PPI, pacemaker lead. And we gave him a blood transfusion that night. So next day I come back, his face is swollen yahan. He's got full, and his arms are swollen. And I'm thinking कि एक दिन में हमने थ्रोम्बोफ्लेबाइटिस कर दिया, हम करते हैं, but 2-3 दिन लगाते हैं normally हमारे hospital में. पहले दिन ही कर दिया दोनों हाथ में. So I couldn't figure. Then I thought it was maybe just the blood transfusion that did something. And I said, look, and by that time he had so much of swelling that he was having a little bit of pressure on the trachea. He couldn't breathe properly. He was swelling a little this way. Very lovely, pleasant gentleman. Wouldn't complain about it. So I said, look, I'll give him some hydrocort. And I said, look, we'll just watch him for some time. And while all this was happening, so I said, why did he have the anemia? I'm not very sure. And I just decided that I would do a PET CT whole body. And I was saying, let me look for any kind of internal malignancy, and it's not all adding up. I'm not sure of that. So I do the PET CT in the morning, next day morning. Evening, my nuclear medicine person calls me up. I said, typically our conversation is there anything? Lovely person, she typically says, but Reddy, no malignancy, nothing. I said, okay. The next morning I come back and I say, his thing is increased, his puffiness has increased, but this is sorted out. So I called her back. I said, Dekho, I don't want to get a CT of this area, I've already done an ultrasound. They've just said that there's soft tissue edema. And can you look at this neck again, because PET CT हुआ है, just look at this. So she calls me back, she says, वो सब ठीक है, जहाँ IVC में pacemaker lead पड़ा है, here's SPC thrombus. And he had an SPC thrombus.
Right.
And I took him up and we did a thrombosuction. We emptied up. He had occlusion of the brachiocephalic, the subclavian, all were there. And the moment that the next morning is fine, all his wrinkles are back. And so I'm just saying, we order a test sometimes thinking.
Cause of anemia, sir?
The cause of anemia eventually turned out to be predominantly only nutrition. We didn't find anything else.
Okay,
the rheumatologist saw iron deficiency, etc.
My last question, Dr. Reddy, would be regarding the 20 to 30% of the patients would be refractory to the first and the second line therapy. So, what would you prefer? Which map would you prefer? Would you prefer tocilizumab? Would you prefer botensilimab, tocilizumab, or the latest, which is the inizumab, which has recently been approved for the neuromyelitis? So, which map would you prefer?
For neuromyelitis optical spectrum disorders, the eculizumab, the satralizumab are not available here, sir. We use only rituximab, or we use azathioprine or mycophenolate. These are the standard options that we have available. The drugs that are FDA approved are not yet available. 3 of them.
Thank you, sir.
Friends, only 3 minutes, 2 for Dr. Kalra and 1 for Dr. HPC, sir. No.
पहले तो नाइंसाफी डॉक्टर चौहान ने कर दी 8 में से 6 और 2. Anyway, sir, one new app has been developed by one of my friends from Bhiwani that if you are drunk, your car won't start. This has been very much, it's very popular. It's coming. Tesla people have hired him with a very huge amount. So, COVID infection, it was very much notorious for so many new things, myocarditis and all that. Did it cause encephalitis also? Because there were so many antibodies developed. And also, sir, COVID infection versus COVID vaccine, they are not so different. We are giving the same antigen. So I want to know your comments about the effect of COVID on autoimmune.
I think that any infection would trigger an autoimmune reaction. There's no question of that. I think that any vaccine could also trigger an autoimmune reaction. But I think that our knowledge of this has been slightly limited because I think actually none of us really, to my mind, actually went into COVID areas properly. If you look at the kind of data that we got, it was all second-hand data. All the people were sitting outside, there were a few people inside, they were getting it. And to be honest, it was the worst time that for a doctor because I do not think that, in my mind, that most COVID centers in India did any justice to the patient. It could be a lack of knowledge of this and that, but I don't think...
Let me answer this.
After my
Few patients had CSF positive for COVID-19.
Sir, my last half 2 questions are, what about stem cells? Are they also going to be helpful? Anything?
In the last 20 years that I've been associated with stem cells, I'm not seeing definite proof of utility.
Still experimental, sir.
And my last half question and my understanding, I want to know if encephalopathy also at times makes the things more confused because there are encephalopathies happening.
When you say that there is a metabolic encephalopathy also.
Yeah.
So you're right, sir, because देखिए वही मैं कह रहा था कि sometimes there is a multifactorial thing. My whole thing is that if it's very clear, like for example, if a person comes with a very low sodium, he's on a diuretic which causes that low sodium, everything adds up, and you don't have a problem. But if otherwise, it's a common thing. It happens in so many things. We have to start looking at that as maybe just a bystander.
Sir, Dr. Reddy sir, Dr. HP Singh sir has a question. I am coming to you, sir.
Very simple question.
Very good.
Autoimmune encephalitis. This is 100%
No, it's not 100%.
Number 2. Why, sir?
Because at the end of the day, the inherent nature of disease is such that if you have, it's like saying, if you have lung cancer, I'm just saying that, will everybody die? No. 50% people, if they diagnose early, they will completely go. 50% won't. They'll have treatment and they will have a shortened life expectancy and they will eventually, depends on the stage that you catch. It's the degree of disease that decides.
You mean to say this is like a cancer?
No, it is.
Thanks for your statement.
What I'm trying to tell you that each disease inherently has its own, way of playing out. So suppose I have an 80-plus-year-old person with encephalitis and a 40-year-old with the same degree of encephalitis. The different encephalitis. So that's the outcome may differ.
Now my next question. There are so many encephalitis in the system. So many. Take example of brain, bacterial, viral, liver, kidney, so, blah, 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 blah. So my question is, what is the difference between all blah, blah and autoimmune encephalitis? Then how can we recognize the patient come to us? If this is the patient, you have to refer to you. So how can we?
So if you have a psychiatric presentation in a person who has never had a psychiatric problem, if there is, an MRI, EEG showing somebody who suddenly started having seizures, who has never had a problem, let's say at 35, 40 years of age. When we do MRI, there are certain changes that occur in the MRI which suggest that this is possibly autoimmune encephalitis. So those are the kind of patients that we look at.
सर यू आर वेरी राइट। जो हमारे पास पेशेंट आता है 200 रुपये MRI की बड़ी बात है, वो तो CBC भी नहीं करा पाता, हम कैसे पैसा आएंगे? ऐसे कौन से सिम्टम्स है कि हम कहें कि नहीं आपके पास आए?
कोई अचानक से कोई बीमारी शुरू हो गई, कोई बिहेवियरल चेंजेस जो अचानक से हो गए हैं, तो अब तो ब्लू है पेशेंट कहता है कि मैं बिल्कुल ठीक था। अगर कोई आदमी कहता है कि 10 साल से इनको ऐसी हरकतें कर रहे हैं, तो उसमें हम नहीं बनी कर रहे हैं।
My last question. How much is this is fatal? कितने % डेथ होते हैं?
Sir, I would imagine that autoimmune encephalitis would possibly, in my understanding, and I don't think that there are any such figures, I would imagine that death का मतलब आप कह रहे हैं कि उसी समय या 6 महीने में या 7 महीने में?
नहीं करा सर, आप कहते हैं 10-15% हो जाते हैं।
मरना
कितने हैं?
10 मरना तो सबने है, but that's not the point.
नहीं, सबने तो करना सर, हमारी किस बीमारी से कितने?
मतलब what I'm saying generally, but I'm just trying to say 10-15 पेशेंट रोज नहीं आते।
आपने स्टेटमेंट कहा है।
नहीं सर, 10-15 नहीं, 10-15 सर एक मिनट।
महीने में आते हैं ना, तब भी ठीक है सर, महीने में तो 15 बहुत बड़ी फिगर है।
नहीं 10-15 हमने कहीं बजा ऐसे कि at least 4 to 5 per month is starting to identify.
Sir, Dr. S.K. Singh sir, Dr. H.L. Mathur actually touched my heart last CME when I stopped him from asking questions. So when we were, no, can I have just 2 minutes please? So he told me, Dr. Chauhan, मैं बहुत पढ़ के आता हूँ, मुझे सवाल पूछने दिया करो. Here is Dr. H.L. Mathur.
NMDA, autoimmune encephalitis. There is, you see, sir, neuropsychiatric symptoms also. How we can distinguish it from the primary neurological disease. Guided upon these things, it affects the hippocampus region. So what is the imaging, what we will find in imaging? There are IgG antibodies also to this.
Commonest MRI finding in NMDA receptor antibody encephalitis is encephalitis is normal MRI.
Normal.
Commonest finding is normal MRI.
Normal.
You will not find that the clinic.
There are paraneoplastic syndrome also associated with disease.
Paraneoplastic syndromes have a separate set of antibodies. Yes, but so.
Is it associated with this?
Yes.
What are the regions of the paraneoplastic which are involved in this?
So, see, you're saying that what are the kind of presentations? So you can have a limbic encephalitis, you can have, that's the commonest.
Temporal lobe.
No, sir, what are the tumors which are associated? Just we say ovarian teratoma. There are other tumors also associated.
Thymic neoplasms, malignancies of the lung, all these are known to us.
Friends, I think we had set out 10 or 15, it's already 10:25. We are extremely grateful to Dr. Rajasekhar Reddi sir to do a wonderful CME for us, and it's the time for the moderator, Dr. SK Mathur sir, just to summarize it in about 2-3 lines only.
It was a wonderful talk. It sensitized us to know what is autoimmune encephalitis. So we should be we are sensitized about it, and we should be thinking about the patient who can be an autoimmune encephalitis. And every diagnosis, every treatment is hallmark of management, and we should refer our patient to either sir or him or anybody who can handle the autoimmune encephalitis. Suspicion is very important, which you are sensitized us, whom we suspect, and how do we manage them. Though management is the outpatient department, bias will not be possible. We have to send to a respective center that all investigations be done and treated. Thank you, Dr. Reddy, for a very nice talk. Thank you so much.